after medical break. Just before we start, just a reminder that to please leave your questions till the end of the presentation. You can enter them in the chat. And please let us know that you were present today for these rounds by answering a short survey that you will receive right after the presentation. It is really a great pleasure to introduce today's speaker, who's coming us from the Department of Surgery. She's already known to many of you and needs very little introduction, but we'll find out a little bit more about Dr. Feldman. She is the Edward W. Archibald Professor and Chair of the Department of Surgery at McGill University and Surgeon-in-Chief at the McGill University Health Center. Her clinical focus is minimally invasive gastrointestinal surgery, and her patient-centered clinical research program focuses on improving recovery and other outcomes of abdominal surgery. This includes measurement of patient-centered outcomes during surgery recovery, optimization of perioperative care processes, and technology-enabled assessment and improvement of operative performance. Dr. Feldman established a multidisciplinary group implementing evidence-based enhanced recovery perioperative care plans at the MUHC, which was recognized as a leading practice by Accreditation Canada. She was a James traveling surgeon and received the Canadian Association for Medical Education National Award. She is a member of the Executive Council of the Society of American Gastrointestinal and Endoscopic Surgeons, where she's currently serving as president. She has had leadership roles at the Canadian Association of General Surgeons, the Fellowship Council, and the American College of Surgeons, where she co-chaired the ERIN, Enhanced Recovery in NSQIP. Liane, you'll have to tell us what that is. Collaborative helping hospitals implement care pathways to improve resource use and outcomes. Dr. Feldman is the author of over 300 articles, book chapters, and videos, and is co-editor of 3 books, including the SAGES Eras Society Manual on Enhanced Recovery for Gastrointestinal Surgery. And I'm hoping, having Dr. Feldman here today, that we can learn a little something in the Department of Medicine about enhancing our recovery in the things that we do every day in medicine. So Liane, thank you so much for joining us.
Thank you, Nadia, and it's really a pleasure and honor to be here, and certainly a privilege to talk to you at Grand Rounds today, and really just to talk to you about the culture change that we've undergone in the Department of Surgery at the MUHC, increasingly using these kind of standardized care pathways for throughout the trajectory of perioperative care, and hopefully there'll be some areas where we see some overlap, and I'll be happy to, take questions and have some discussion. I also would say that we do have an amazing perioperative medicine group that works with us very closely, but you'll have to invite me back another day or invite one of them to talk about their work, because I'm not going to talk about prehabilitation and that kind of thing today, but there's some great work being done. I don't have any financial disclosures. What I want to talk about is something I've been interested in for a very long time, which is about what does it mean to recover from an operation, and a little bit about why it takes so long to recover from an operation and how we can fix that. That's the surgeon mindset. And then I'm going to talk to you about really mostly what I'm going to talk to you about is reorganizing surgical care around patients using enhanced recovery after surgery, or ERAS programs, or enhanced recovery programs. I'm going to use all those terms interchangeably. And I'm going to describe, summarize a bit for you what we've gone through at the MUHC implementing this approach to perioperative care. So, I'm going to show you some surgery picture. This is only one surgery picture, but I can't do a talk without at least some surgery picture. And, this is a picture of a really nice operation being done for an advanced gastric cancer at the G junction through thoracoabdominal approach. And, this is pretty serious stuff. And that provides the chance to cure for many diseases, including this kind of cancer. But of course, there's a cost to surgery, and the cost to surgery can be measured through the metabolic response to trauma. You might remember from your surgery rotation, there was probably a chapter in the manual that talked about the stress response to surgery, which is mediated by afferent nerves and cytokines generated from the site of injury. And the net effect of the stress response is increased secretion of catabolic hormones, including ADH, cortisol, catecholamines, really to provide food substrates from catabolism of carbohydrate, protein, and fat, and to maintain plasma volume. The extent to which the stress response is evoked parallels the degree of tissue injury. And this probably evolved so that injured animals could crawl to the back of the cave and catabolize their own tissue for fuel, but one might argue that we don't need that anymore. Now, insulin resistance and hyperglycemia are key markers and modulators of the stress response to surgery, and that's actually been called the diabetes of surgery. And this is the result of increased glucose production as well, that's driven by cortisol and catecholamines, and also peripheral insulin resistance, resulting in decreased peripheral uptake of glucose. When we ask surgeons what's important, what do they think is most important in recovery after surgery, surgeons always start with complications. Complications are very hard on patients and they're very hard on surgeons. And they're not that uncommon, even especially after major surgery. This is just an example from a large data set with about up to 45% of patients, let's say, having esophageal cancer surgery, having a complication in this data set with a mortality of 4%. When we ask patients, what do they consider important in postoperative recovery? Patients never say complications, even patients who've had complications. This is a qualitative study that we did interviewing 30 patients from different countries about what was important to them in recovery, and they talk about functional status, returning to habits and routines, regaining independence, enjoying life. And we can sort of model the trajectory of perioperative functional status in a pretty simple way. We can measure something around functional status in the preoperative period. And we know that if that drops below a certain level, a patient may no longer be actually independent for their activities of daily living. And we know that surgery and the metabolic response to surgery is associated with a rapid decline in functional status. Traditionally, that's been required a period of hospitalization. And I'm going to show you how that period has gotten shorter and shorter, which is followed by a period of over weeks or months where there is return to baseline functional status, or perhaps even above baseline functional status. And where complications fit in is that complications delay this period of recovery, and there may be patients who, of course, never regain back to their baseline independent status. This is a study we didn't do that I wish we had done. I think this is a really great study where it's a little bit old, but looked at what's the incidence of this kind of persistent disability 6 months after really major abdominal surgery. This is in older patients over 65. Where 20% of patients, even 6 months after surgery, had not regained back to their baseline instrumental activities of daily living, so things like shopping or housework. And when you looked at measures of muscle strength, so directly related to that catabolic response that I mentioned, up to 50%, more than 50% of patients, older patients after major abdominal surgery, were not back to their baseline strength, even 6 months after surgery. Factors that were associated with poor recovery, again, serious complications, and also baseline physical status, as well as other factors as well. So I thought Nadia introduced me as a GI surgeon, and when I started my surgical residency, this was a very, very exciting time in the early 1990s, where minimally invasive surgery was basically being kind of invented in front of our eyes, and new procedures were being introduced and developed, including at our place here as well. We saw that our patients just looked a lot better after minimally invasive surgery. And to me, that I thought that that was really the way, that was the answer, that was going to be the answer to really abrogating this metabolic response to surgery by decreasing the tissue injury that was required simply for access to wherever you were trying to operate on, by decreasing that tissue injury either through the abdominal wall or the chest, that would naturally result in an improvement in recovery for patients. When we started to look at that, and we started with a very simple operation, laparoscopic cholecystectomy, lap chole. Has been a day surgery operation for a long time. The length of stay is about 3 hours. And when if you ask surgeons, how long do you tell your patients it takes to recover from a lap chole? Most of them will say about a week. So we looked into that, and we started to measure that using, as I mentioned, the measures of functional status or self-reported physical activity. We found, to our surprise, that a month after lap chole with 0 length of stay in hospital, less than 50% of patients were actually recovered to their baseline physical activity, and it tended to follow, the little model that I showed you. And that was because lower intensity activities, yes, they were recovered by a week for sitting on the sofa, but if they were doing any higher intensity activities, that was where people weren't yet recovered by a month. So that was a bit surprising to me. And part of my surprise is related to the fact that we kind of work in we're pretty siloed. For me, when I looked at surgical stress response and all the symptoms and signs that are associated with surgical stress, that are all the factors that delay recovery, as I mentioned, to me, the answer was going to be minimally invasive surgery. And it is true that minimally invasive surgery does result in lower metabolic stress response. But what I wasn't paying attention to as we were developing and really focusing on our surgical techniques was that there are a lot of other important ways to mitigate the surgical stress response that I wasn't necessarily fully aware of, that were being developed, mainly in anesthesia. So things like neural blockade, pharmacologic interventions, and other interventions having to do with fluid and temperature and so forth, were also being developed at the same time outside of the traditional purview, let's say, of the surgeon. But the thing is, if we only focus on that one element that's really that we have control of, and we think we have control of, and that we don't focus on all these other things that are happening to surgical patients around the surgery, then they won't get the benefit, even if they have the most perfect operation. And this isn't about evidence. I know that all of you will have similar examples in what you do, but I mean, there's lots of evidence for best practices in perioperative care. This is just a few pictures of some guidelines that there are for various operations for best practices in perioperative care. Over 20 elements, almost all from strong recommendations, meaning multiple randomized trials. Some of these challenge traditions, so we have to start doing something new, but the vast majority of them, or a lot of them, are not about implementation, they're about de-implementation. So stopping to do things that we've done traditionally for whatever reasons, and there are lots of interesting reasons why we continue to do them, but they're not valuable, or they may actually be harmful in some cases. These involve multiple stakeholders, as I mentioned, some of which multiple stakeholders, multiple disciplines and specialties. And the question is, how do we get all of this into practice to benefit our patients? I was going to give you a short little example of how evidence is not enough. If you did your surgery rotation maybe longer than 5 years ago, or you may know this from having surgery yourself or your family having surgery. Of course, we always keep people MPO after midnight because we don't want people to aspirate at induction of anesthesia. Aspiration pneumonitis is a very horrible, serious complication. And so we don't want that. So we keep people MPO after midnight. Where did that come from? This originated from a paper from Mendelssohn in 1946, which described a tragic death of 2 women in labor who aspirated and died from aspiration pneumonitis, who had a full meal 6 hours and 8 hours before the labor under ether anesthesia. this was what led to this MPO after midnight before labor, and then that became MPO after midnight before anesthesia, general anesthesia. And it became kind of that textbook truth starting in the 1960s with very little data to support it, and especially not really consistent with the physiology of gastric emptying, particularly for clear fluids, which is fairly rapid. And of course, there's a downside to being MPO after midnight. It's a pretty long period without hydration and nutrition, especially when most people don't eat at midnight. So let's say you didn't eat or drink from 8 p.m. and maybe you're the last case of the day, you're coming on 18 hours. We're going to be starting to get into some metabolic changes with that. So if we look at what the data is, so there's evidence about this. This is a kind of an old slide, but even back in 2009, Cochrane review of 22 randomized trials, it says that you can reduce the period of fasting to 2 hours for clear fluids without increasing the risk of aspiration. And so that's, we all know that evidence isn't enough to change practice in and of itself, and also guidelines are not enough to change practice because ironically, even starting in the 1990s, anesthesia guidelines were that it was safe to give clear fluids 2 hours before anesthesia and surgery, but nobody was doing this at all. And this is now we're in 2021. So when I talk to surgeons and give this talk and say, well, now that you know all this, who's gonna give my patient clear fluids 2 hours before my operation? And nobody would ever do that. We won't do that because your case is going to get canceled if you do that, or you're afraid your case is going to get canceled if you do that, because what's the first thing that the admitting clerk, the admitting calls you on the phone and tells you to stay MPO after patients and tells patients to stay MPO after midnight the day before. The first thing that happens when you walk in and you sign in to have your procedure, when's the last time that you ate or drank? So, I mean, even these things are not enough to change practice. And that's partly or a large part because we're historically have been very siloed. It's a siloed field that's organized around medical specialties. We each do the best for our patients based on our knowledge and best intentions. And it's the patient, especially when we talk about surgery, moves between the specialties from service to service, but not just about surgery. And that's where I think standardized care pathways like ERAS can play a big role. So ERAS is the implementation of patient focus. So we're going to reorganize care now around patients who are having a particular type of common procedure generally standardized. So we're going to come to a consensus between the various disciplines taking care of these patients that we're going to have a standard approach to our care for these patients, and we're each going to follow that pathway. It's evidence-based, so it's a way to get what's in guidelines into practice. And it's an integration throughout the perioperative period. So integration of perioperative, intraoperative, and postoperative periods. And as I'll show you some data, that implementation of these programs is associated with a decrease of postoperative complications. It reduces length of stay without increasing hospital readmissions. Also, of course, we have to do more with less. We look at the old Vic. Not that long ago, there were 1,000 beds at the Royal Vic, and now when we moved in a few years ago, we moved with 346 beds. In surgery, as in medicine, there was a decrease in the number of beds that was from one day to the next. And so really, this is about improving value. Value being defined as health outcomes that matter to patients, such as functional recovery, I think, relative to the cost of achieving those outcomes. So to improve value, we can either improve outcomes without raising costs, or we can lower costs without compromising outcomes. And this isn't about accepting worse outcomes because they cost less. And in fact, bad outcomes usually cost more anyways. So how did we get involved in creating these pathways at the MUHC? And for me personally, so about 15 years ago, we became interested a little bit in implementing some standard pathways. There was some work on this called fast track surgery coming out of Denmark with led by Dr. Henrik Kellett. He'd been a visiting professor here as well. So we had dabbled in this a little bit of creating pathways around some of our, I wouldn't call them enhanced recovery pathways, but just standard order sets. And my mentor, Jerry Freed, was asked to write a book chapter, and so about this, and so he asked me to write the book chapter, which, as a good mentee, of course, I said, sure, I'm going to write the book chapter. Of course, I didn't know anything about it, and I was going to be writing a revision of a book chapter written by Dr. Kellett. So I wanted to do a good job. And luckily, I could work with Franco Carli, who was the previous chair of the Department of Anesthesia and actually knew an expert in surgical metabolism. So that was really helpful and knew a lot about this stuff. And so we did write the book chapter. So to write the book chapter, of course, since I didn't know very much about it, but I do like to over prepare for things. I sat down in my chair for a while, and I just like immersed myself in this literature a while back. And then I just said to myself, I said, I thought, wow, this is really, we should just do this. We should implement these standards pathways, and this is a great way to get evidence into practice, and why aren't we doing it, and why is there so much variability? That was a little bit naive, I guess. And I also thought that most of the evidence at that point and most of the studies were being done in colorectal surgery. But I thought to myself, well, if we just do this in colorectal surgery and we reduce the length of stay in colorectal surgery, all that will mean will be like lots of patients, trauma patients that are in the hospital, or we're very interconnected. We don't have like a unit that's just for arthroplasty and a unit that's just for colorectal and a unit that's just for thoracic. I mean, they are concentrated in certain areas, but when there's a bed, there's a bed, and we just, so we're very dependent on each other. So I thought, well, if we're going to do it, we should do it for the whole department, which turned out to be quite probably a little bit naive. So this is how we got started. So we started back in 2008 with a working group at the MGH. That was our mission, to implement these multidisciplinary ERAS pathways across the department. It was, we initiated by clinicians, so it was more like not a top-down type of thing. And the vision would be that the pathways would be the standard of care. We wouldn't be selecting patients to be, to be on the pathway. Dr. El Hilali was the chief at the time, the late Dr. El Hilali. I asked him, I often asked for lots of things. I'm not sure why this one worked out, but whether we could have a coordinator for as a pilot for a year. And it was Debbie Watson. She's still working on it. She was a pre-op clinic nurse who was like the nurse that would call you and tell you, the platelets are really low, the glucose is really high. So I knew that she would be kind of very invested in helping us do the right thing. And as a full-time coordinator for the program, we created a multidisciplinary team. We actually had weekly meetings for quite a long time to get it off the ground. And at the same time, had a strategy for how we were going to audit and evaluate this. So that when Dr. El Hilali asked me, well, wasn't quite a year later, he probably forgot about it, but when he did ask, how's it going, we were able to show some pretty compelling data that this was going to be a useful thing to do. And so this position became a permanent position in 2010 at the MGH. And then we expanded this because it was quite useful to the RBH in 2014 under Claude Poisson. So both of these people remain the coordinators basically doing all the work. So how does this work? We look at the different interventions that are involved in perioperative care, and these can be operationalized differently depending on the procedure, of course. But basically for pre-op, we look at how we're going to educate and activate engaged patients in a pathway. I'll talk a little bit more about that. We look at medical optimization, and sometimes prehabilitation, which is a great program. And if you haven't had rounds on it, definitely should get their team to talk to you about this. Reduced fasting, as the example I gave you, and using some oral carbohydrate loading as well. Intraoperatively, we tried to use minimally invasive surgery whenever we can, or whenever that's appropriate. We look at fluid balance, surgical site infection prevention through a bundle of interventions. We look at what kind of regional anesthesia or nerve blocks can be used. We looked at postoperative nausea and vomiting prophylaxis, because that's very important in terms of what we're going to do post-op, which is immediate nutrition. So oral nutrition, oral nutrition. So we're not keeping people MPO if the evidence doesn't support that that's necessary to do. So all the stuff that I saw growing up in surgery of keeping people MPO until they, had return of bowel function. That's, with an NG tube and all that, that's not what we do anymore. Getting people out of bed immediately, but if they're vomiting because we didn't, we didn't prevent postoperative nausea and vomiting well, then that's not going to work. So it's all kind of connected. Postoperatively, very focused on multimodal opioid-sparing analgesia, minimizing tubes and drains. That's a whole other story about the traditions around when to use different tubes and drains. Getting the IV fluid out, depending on the procedure, but it might be actually right away once they come up from the recovery room. And very importantly, using these kind of daily care maps. So each day a patient is aware of what's going to be happening to them that day, and that's consistent. The nurses are aware, the residents are aware that that's what's happening on each day, and setting out transparent discharge criteria. What's keeping a patient in hospital today? Thinking about that in advance and setting out, if the certain discharge criteria are met, a patient is walking around, pain is controlled, bowel function, etc., is there, then that patient is ready to be discharged, rather than kind of thinking about it every morning as we round to say, make that decision kind of, and then there's a lot of variability in that. So how does it look? We have a steering committee at each site that is led by the pathway, our coordinator. It has a surgeon and anesthesia leads. We've always involved the nursing leadership and frontline people right from the beginning. We have nurse specialists in pain who are extremely helpful, physio, nutrition, pharmacist, and librarian. Librarians always been really, really helpful in terms of finding literature for us, finding the guidelines, finding the evidence, and that's a really great way to come to consensus. And then for each pathway, we work with the clinical leads from surgery, anesthesia, and nursing who really own the pathway. And work on leading it for their groups. The goal is really make it easy to do the right thing. That's what we want to do. And so to do that, we create standardized medical orders. This is what each pathway includes: standard medical orders, anesthesia guidelines, so intraoperative anesthesia guidelines, nursing standards, the patient education piece, some training of the nursing staff in the preoperative clinic and on the floor, and we might tell the residents that it's happening sometimes, and some approach to audit and revision. So when things were really paper-based, this is what some of it looks like, and then we also always create a patient version of the pathway, as well as I mentioned, with a target length of stay that we agree on, and we try to push it, and for each day what the benchmarks are and what the patient can expect for each day. And we don't launch a pathway without having this kind of patient version of the pathway, and I think that's been a very important component for us, because really things have changed a lot, and we do think that having patients actively engaged in their care is very important. This might be what you think of, what we think of when we think about like major surgery. This is second day after an esophagectomy, we put always the patients almost all the patients went to the intensive care unit. And even if they wanted to get out of bed, they couldn't because they were literally taped down to the ground here. When we developed the pathway, originally our target length of stay was 7 days. We had no patients that went home at 7 days before the pathway. But this is what patients look like now. It's that a lot of things have changed with minimally invasive surgery, advances in anesthesia, immediate mobilization, better nutrition, and so forth. And we've about 60% of patients home by post-op day 7 now. The target length of stay now is 6 days. And each element of that has been questioned. It's not just a matter of saying a patient should be kicked out of hospital early. It's a matter of people meeting milestones earlier. I think that we're just at the tip of the iceberg with this concept of patient activation or patient engagement. This is a study that Teddy Dumitra did. She's a STAR general surgery resident who's just finishing up a PhD, where she measured patient activation for patients having major surgery. And we had about a quarter of our patients having low patient activation, which was associated with increased odds of complication, longer length of stay, and more unplanned healthcare visits after surgery without any difference in readmission, suggesting that this might be a actionable risk factor. As I mentioned, we create these kind of daily care maps with discharge criteria for patients and get everybody on the same page. We've created over 20 of these pathways, I think 25, something like that. They are basically touch from very simple procedures to very complex procedures. Now I'll tell you a little bit later about how we're really pushing towards more same day surgery. But this goes from very simple operations like ambulatory hernia surgery to very complicated operations, including transplant, cystectomy, esophagectomy, so forth. It really involves basically every division in the department except cardiac surgery, but working very actively on implementing a pathway in cardiac surgery. And some of our more complex ones as well, like cardiac surgery, like head and neck cancer with reconstruction, involve ICU stays. And all people that are involved in caring for these patients have to be involved in creating these pathways. We'll look at some of the data for the effectiveness outcomes and cost data as well. This was work that was done by Larry Lee, who's a colorectal surgeon with us. This was, he did a PhD in health economics looking at this. When we looked at one hospital, two high volume colorectal hospitals, one with enhanced recovery pathways, one without, with more conventional care. The patients in the enhanced recovery pathway were meeting discharge criteria earlier, recovery milestones earlier, such as being out of bed, not needing IV fluids, return of bowel function much earlier, and tolerating diet much earlier and removing drains earlier. And this was also associated with a decrease in the length of stay from the traditional 7 days after colorectal surgery, which would be sort of a very traditional hospital stay, to about 4 days. And this wasn't just laparoscopic and open surgery. Decrease in 3 days of the length of stay. Without any impact on readmissions and without any difference in the incidence or severity of complications. And when we look at more patient-centered outcomes, looking at lost days from work, so this was also less in the enhanced recovery hospital patients. And also we looked at, one of the questions was, are we just shifting the burden of care from in-hospital to out of hospital? We looked at caregiver days off work, and in fact, they were less in the patients coming from the enhanced recovery hospital. And again, those unplanned healthcare visits were actually less in the patients from the enhanced recovery hospital. when we looked at costing, costing that, so this here is a mean difference in Canadian dollars. This is favoring the ERAS hospital, favoring the traditional care. We looked at institutional costs. This was about $1,000 less for in the Enhanced Recovery Hospital. That included all the implementation costs for the pathway, and that was not statistically significant. Same with healthcare system costs. That includes CLSC visits and physician remuneration, and about $1,600 cheaper for the enhanced recovery patients. But again, that was not statistically significant. But when we put it all together, we look at it from the perspective of society, including lost employment days and caregiver days off work. There was a savings of $3,000 per patient in the enhanced recovery patients, which was statistically significant as well. Where are these cost savings coming from? This is a different study. This was in esophagectomy. And really, this is about partly about de-implementation of low-value care. So we have savings in lab costs, we have savings in pharmacy costs, we have savings in imaging costs for the enhanced recovery program. And we had decreased ICU costs and decreased length of stay, so decreased hotel costs, which altogether was about a cost savings of about $2,700 per patient. I don't know where this money is, but someone's using it for something. And this is consistent across the various procedures that we've looked at across various kind of divisions across the general and the VIC, with patients meeting discharge criteria sooner, shorter length of stay by anywhere from 1 day to 3 days, depending on where we started and what kind of procedure it is. No difference in readmissions, and most of the time, no difference in complications. In lung surgery, there was fewer complications. I'll tell you that story in a second. And either hospital savings or societal cost savings. So most of the time, we haven't seen a difference just in our single center studies in complications. One area where we did see a difference in complications, this is a study before and after study with in lung resection, where we did see a decrease in complications after the pathway was implemented. This was mostly because of a decline. This was a decline in urinary tract infections. This is, we think, closely linked to the fact that the Foley was being removed because of the pathway about 90% of the time on post-op day 1, which is what the pathway said to do, whereas before the pathway was only removed on post-op day 1 about half of the time. Now, the irony is that we know that there were trials. We all know that evidence isn't really easily implemented into practice. We know that the trials, people don't like to take out a catheter when the patient has a thoracic epidural because of the increased risk of urinary retention. But there is a randomized trial that showed that early removal was safe. It reduced UTIs, and there may have been a little bit more need for in and out catheterization, but no difference in reinsertion of the Foley. The irony is that we did this study. This is a study we did at our place, and we still didn't implement the evidence into practice until we had these pathways developed. So is this something unique to us, or how is this generalizable? So this is a project we did with the American College of Surgeons, the NISQIP, so National Surgical Quality Improvement Program, which is a program where risk-adjusted outcomes are fed back to institutions. About 900 institutions participate in this program. So it's a big quality improvement registry. And the goal here was to coach 15 hospitals to adopt ERAS for colectomy surgery. And they were different kinds of hospitals, big and small, community, academic. And we did some, this was a guided implementation over a couple of years. And we developed new audit measures that were used as part of this data collection to track care processes and outcomes. And we looked at length of stay before and after implementation in the pilot hospitals. where the patients in the pilot hospitals were propensity matched to other patients having colectomies in the non-pilot hospitals, but everybody was involved in this quality improvement database. And what we saw was that the length of stay actually decreased in the control hospitals, which decreased over time, decreased more in the pilot hospitals. So with this kind of unadjusted difference was 1.3 days, but in a hierarchical linear model where it was adjusted for patient risk factors and clustering within hospitals and matched pairs, the pilot remained significant with an adjusted decrease in length of stay by about a day. So that's a lot of numbers. How do the patients look? This is a patient, not all the patients look like this, but this is a patient post-op day 1 after a laparoscopic right colectomy. He had an intracorporeal anastomosis. He had a transversus abdominis plane block. He got all of our enhanced recovery stuff. He has no intravenous. He has no drains. He's drinking water. He had breakfast. In fact, this particular patient at the Montreal General had gone out without telling anybody in the morning for some bird watching and then came back to his room. So you have to start to wonder about some of these patients maybe don't need to stay in hospital at all, and actually what happened to that stress response. So this is an RCT we did. The details are not really important, but it was about the impact of a complex carbohydrate drink compared to a simple carbohydrate drink on insulin sensitivity, which, if you remembered from the beginning of this talk, is the main marker and modulator of the surgical stress response. And we used the gold standard measure of intraoperative insulin sensitivity, which is hyperinsulinemic euglycemic clamp. And the model we used was laparoscopic colectomy. So basically, you give a constant dose of insulin with simultaneous glucose infusion at variable rates. And the lower the glucose infusion rate required to maintain euglycemia, the higher insulin resistance. And at steady state, the infusion rate of glucose necessary to maintain euglycemia is equivalent to glucose disposal in the muscle. And preserved insulin sensitivity is defined as greater than 5.5 milligrams per kilogram per minute. And all you need to know is that in older studies with open colectomy and without enhanced recovery, there was a 70% decline from preoperative insulin sensitivity. Now, in our study, when we looked at this measure of insulin sensitivity intra-op, we didn't find any difference between the simple and complex carbohydrate drink. But part of our problem was that people didn't have insulin resistance anymore. 76% of these patients had preserved intraoperative insulin sensitivity, suggesting there's been a really big impact on the surgical stress response. So that kind of makes you think, what are people staying in hospital for anymore for some of these procedures? And if we look at sort of traditional care after bowel surgery being a 7-day length of stay and NG and pure misery, and then we worked a lot on getting to an enhanced recovery pathway of 2 or 3 days and then 1 day. And then you wonder if patients need to stay in hospital at all. Now, we're very highly motivated to have hospital beds. Just overall, mostly talking here about scheduled or planned admissions. We use about 25 to 30% of the total beds in surgery for these planned admissions. The other 70 to 80% are for patients that are unplanned or from the emergency department or other places are transferred. And over time, what that translates into is lower and lower number of beds. This is the general, this is the Vic, the general in red, the Vic the general in blue, the Vic in red. The number of average beds that we used for scheduled admissions is extremely low. So up to before COVID for fiscal year 19, we used on average 25 beds for all of our planned surgical activities at the general and 42 for all of our planned surgical activities at the Vic. And the number of patients for that has not decreased, so about 14,072 in 2017, and that actually increased and then stayed the same. So, the concept of really trying to do as much as we can with what we have. And of course, cancellations for lack of beds is on the same day of surgery is terrible for everybody. It's terrible for patients. It's terrible for surgeons and everybody. And, when we look at what our wait lists are, especially in COVID, last week we had 11 cancellations at the MGH just in 1 week alone. So we are, it's true, very, very highly motivated to do the most we can with the resources that we have. And in COVID, that helped kind of introduce this concept of same-day discharge for these more complex procedures. Patients, we had fewer beds. Patients also did not want to be in the hospital. And this is work that, again, Larry Lee is leading, who's now one of our colorectal surgeons. So same-day discharge after colorectal surgery, colon resection, rectal resection for cancer. With also a digital health application, which allowed for direct messaging from patients. This recruited about 30% of the patients being operated on during this time period. And this is just something that he just put together pretty recently, but 70 patients who were recruited to same-day discharge for the colorectal surgery. 55 of them were able to be discharged on the same day, and none of them came back to the emergency room within 72 hours, which is our a priori sort of safety outcome. Patients also were quite satisfied with this. We're prepared for it, and we're motivated to succeed at this. The patients, most of them didn't feel that they needed to stay in hospital. We're happy with the recovery at home, and we're happy with the ability to communicate through the app. And this is really a big part of what we're working on now for upper GI benign disease like reflux surgery, paraesophageal hernia, pretty big operations. We've been doing that for a few years. About probably over 200 patients have been discharged the same day of surgery. Colorectal, we're probably close to 100 patients now. Hip and knee arthroplasty as well, about 100 patients that have been same-day discharge. Bariatric surgery, so sleeve gastrectomy, we started that in COVID, about 30 or 40 patients so far, and we are working on a pathway for same-day discharge for a lung resection, so video-assisted thoracic surgery resections. So I'm going to wrap up here just to summarize what I think we've gained through adopting this care pathway approach, which I think essentially it's not rocket science, but it is a platform that helps get evidence into practice. I think it's been shown to be quite applicable across a wide range of procedures in a wide range of institutions. It's really about integration of care, interdisciplinary integration of care in a patient-focused way, which decreases variability between practitioners and at the end of the day improves the value of what we do. So thank you very much for listening, and I again appreciate very much the privilege of the podium today and look forward to any discussion.
Thank you, Liane. Honestly, really, really terrific. Really, congratulations on all of this. It's innovative, quality, dealing with quality, cost, access, everything that you would want in an academic institution. And I'm looking at there's lots of comments coming in. Mark Rogers says, brilliant body of work, Dr. Feldman. Seems like centers reinvent care path wheels. Are there effective national, international bodies that work ERAS guidelines and implementation?
Yeah, thanks, Mark. For ERAS, yes, there's a whole ERAS society that really came out of Europe that really put together all of these guidelines, the ones that I showed at the beginning of all those perioperative guidelines. And there's an Enhanced Recovery Canada, ERC, that also has, that's a part of Patient Safety Canada, I think is the organization. That's really doing a big push on enhanced recovery. Alberta did a province-wide implementation of ERAS and showed a really significant return on investment. I don't know that, I think that they're, in terms of reinventing things, I think that it's like, I think it's important that centers do reinvent it a little bit, because it's, I think you look at what the concept of what the specific intervention is. Let's say it's opioid sparing analgesia. Some centers are really great at regional blocks and other centers are not. But they want to get at multimodal, opioid sparing analgesia, and they should get at it in whatever way is best for them. I think it's more important than having a specific modality that's used. More important is the work to create your own pathway for your own group that works for you. And I think that that's where the kind of adherence comes from, is the work that it takes to build that team that owns the pathway and is sort of that clinical champion, rather than a specific, it has to be, a specific thing for each place.
Thank you, Liane. There's a comment here about elderly populations. Is there it should include elderly friendly approaches, AAPA, AINEES, with particular attention to delirium condition. Any comments on that?
100%. So we do elder friendly. It's a great way. It's a great way to implement all of those things because it's centralized. So for sure, all of the elder friendly approaches that are institutional specific, because there's certainly an institutional push towards that. And so all of our pathways take that into account. As well as delirium deconditioning. I mean, we have this amazing prehabilitation program. It's internationally recognized. It's something we should all be really proud of in terms of, this is for elective surgery, but we hope, I think that there's applications for non-scheduled surgery or unplanned surgery as well, where because, physical status, functional status, can we improve that in patients that we identify as being at risk? So how can we beef them up, train them up for surgery? So I think that's a really, really important aspect.
Are there other studies large enough to control for cultural diversity and low socioeconomic status? Are there psychosocial members of your team?
Specifically psychosocial members, maybe not, but we definitely, I don't think specifically that those things are controlled for. I think that's a good point. I think where we've come at some of diversity would certainly be in the concept of the patient activation maybe, or patient education, mostly been led by our nursing colleagues, but to be certainly at a level, at a materials that are created in a certain way that hopefully can that a wide variety of people can engage in. But I think your point is well taken. I'm not sure that we've paid a lot of specific attention to that.
I'm going to quote Stephen Grover here saying, fantastic work from planning to execution to systemic evaluation. Everything innovative healthcare and academic settings should be. Congratulations. Now the question, have you had a chance to compare long-term outcomes among patients? There's no question in enhanced care to have enhanced long-term outcomes, including return to full health, but measuring this could be a real challenge. What do you think about long-term care, long-term outcomes?
Measuring all of this has been a very big challenge, as you know, Stephen, for sure. And I think when one area we've looked at longer term outcomes is in this prehabilitation part. I didn't talk about it, which is really using exercise, as you know, exercise, nutrition, and a little bit of psychological, very, very low grade psychological intervention before surgery to kind of train people for surgery or increase physical capacity for surgery. We have some data that was associated in colon and rectal cancer with actually better survival. I think that needs to be shown by other people. But certainly in the pathway of decreasing complications, we know that complications, infectious complications, for example, can impact cancer outcomes. So I think it is complicated. But I think the recovery after surgery, it's probably fairly finite over a period of a few months, but I agree, it's not the easiest thing to measure.
Okay, what about exercise training, muscle strength, aerobic training, high protein, nutrients prior to surgery? And what about nutrition after surgery? Any comment on that?
Yeah, I could talk another, if I had another hour, I would give you the prehabilitation talk, which if you haven't had, definitely worth having, because we have an amazing program in prehabilitation where, exactly as mentioned, it's aerobic, strength training, nutrition, all of those things for we do in patients that we screen, not just for frailty, but we use 6-minute walk distance, nutritional screening, and so forth. In nutrition, for sure, is definitely an issue. We do use protein supplements for patients who stay in hospital, but even better is not keeping people in hospital. But even just the concept of not putting in an NG was revolutionary, 10 years ago, even for colon surgery. And now we kind of laugh at it. Like, why would you do that? It's not useful, it's harmful. And it means that people are starting with being MPO the day before surgery, and then it meant 3 more days after surgery. So I think we pay a lot more attention to physical activity and nutrition, I think, in these care pathways, as you mentioned.
Patsanelli wants to know what happens when someone falls off the pathway. If it's not used, or is there a way of getting back on the pathway?
Right. Fall off the pathway is usually because something's happening. It's usually a complication. And I think, these are not like a recipes. They address, I think, the standard patient, and most like, we're very focused on when bad things happen to good surgeons. So we're very focused on complications and harming patients, and rightfully so. I mean, those are the things, these are the disasters that we all remember. We don't remember the other 99 that everything went well. So I think we have to use our judgment when something isn't going right, and just like always, and a patient's not tolerating, if a patient has an ileus, it's usually because something's brewing. Yeah, so I think when someone falls off the pathway, meaning they're vomiting or something the day after surgery, yeah, we have to dial it back. We can't, that's about, but about 60%, 65% of patients, this is, everything seems to go the way we hope it will.
2 more quick questions, Liane. Great presentation and brilliant results. This is coming from Makeda Samrit. Do you have any lessons how to reduce resistance to change and motivate to adopt multidisciplinary pathways?
Yeah, I think I think people need to be involved. I think, well, there's a few things. So clinical champions that can lead it to their groups. Anything everything pre-printed is very helpful in implementation. Resistance to change, I would say that it's a common question. I can't say that. I think that the goal is to do the work. I guess the goal of this program is to kind of ignore that. So, the resistance to change comes in the room where we're discussing, okay, when are we feeding patients? And a good example would be the chest, like a chest tube coming out and I don't do lung surgery. I don't know anything about this stuff. I'm just sort of moderating it. But people are passionate about the drain needs to come out at this point or not come out at this point. And we have the discussion. Evidence really helps. So the librarian comes with a table, and then we kind of make a plan. Sometimes we make it up because there is no evidence, but we say, well, let's try it this way. This will be what we do. We'll check it out later if it was a problem, and we'll revisit it. I think that's been the approach.
Just in 30 seconds, the home environment, do you assess that? Do you have a team that looks at the home environment?
Not for just, well, for arthroplasty, yes, because that's what was done already, even when we were keeping people for 2 days in hospital. For other things, no. But again, it's not for everybody. So we have inclusion and exclusion criteria for colorectal, for example. it was about 25% of the patients that we thought were eligible for same-day discharge.
So Liane, it's almost 1 o'clock. Thank you so much. We had about 100 members here on this call at some point and on this presentation. And I know you've inspired us. I can see from all the questions, and the questions are still coming in. If we want to do this with some of our members, and I urge everyone to think about, pathways of certain patient populations and who you think pathways would be beneficial. Is there someone you think we could talk to? I mean, you're down the hall, we're all in the same building. Who could help us out to implement some of these pathways for some of our patients in the Department of Medicine? Is there a go-to person?
Well, I mean, I'm happy to talk to anybody as a first step, but I mean, the pathway coordinators do 99.999% of the work. And that's huge. It is an additional resource, but we've shown with our cost data that there's a very strong return on investment. So I think the other thing is that is part of this, and I'll leave it with this last point, is that this is stuff we can do, that clinicians can do. There's a lot of stuff we can't do. The system is so complicated, but we still control what we do to our patients on a day-to-day basis. And quality improvement, it's a job. It's an academic job. It's a way, there's academic rewards that come with it. But there's also just you can see the results, and it's exciting to be able to do something that has immediate impact. And I think that's another reason why it's a rewarding thing to be involved in.
Liane, thank you. And really, thanks everyone for participating. Congratulations on this terrific work. And thank you so much for joining us today. Have a great afternoon, everyone. Bye-bye.
Bye.